Go.
They could picture a judge on a stand in a courtroom. This is a person that's had extensive training in the law. They've had enough experience that they're a subject matter expert in their field of work. They have to objectively listen to all the facts of the case. Everything that's relevant, every piece of information that comes in. If there's anything that's missing or inaccurate, it's going to sway their decision. The decree in the end may be different than if they had every piece of the puzzle. When we place ourselves in this position of judge as a healthcare provider to our patients, we realize that it's our responsibility to gather all this pertinent information regarding a person's total periodontal health in order to recommend the proper treatment for them. We want to customize a plan that's going to specifically target what needs to be done for them. Class, my name is Rachel Pierini, and today's lesson will help you to prepare to become an unbiased clinician that can effectively assess your patient and come up with a plan that's going to be best for them. Let's go over the objectives for today. Following the lecture today, you guys will be able to explain verbally all components of a comprehensive periodontal assessment, correctly explain risk factors associated with periodontal disease. We'll be able to measure bone heights when we're looking at a radiograph to determine the severity of bone loss. We'll be able to compare probing depths and determine what the clinical attachment level is. And then hopefully we'll be able to demonstrate a belief in the importance of having all the information when we're doing an assessment versus having missing pieces. Alright, so before we can conduct a thorough exam, we need to know what we're assessing. We're assessing the patient's periodontium, which literally means around the tooth. So we're looking at those supporting structures. The first one being gingiva, second periodontal ligament, third the cementum, and fourth the alveolar bone. These four elements come together to support the teeth inside the jaw. So the gingiva is our protective layer on the outside. We have the attached gingiva down here, and then we have the free gingiva on top. We have the periodontal ligament here, it's the connective fibers that attach the cementum to the alveolar bone. Alright, so when we're talking about periodontal disease, I looked up some articles in the Journal of Periodontology, and there's two types of periodontal disease. First one being gingivitis. That's our reversible type of periodontal disease. We have changes in the surrounding tissue, the soft tissue, but we have no bone loss. So let me read you what their definition said. Gingivitis is most commonly our body's response to plaque biofilm characterized by swollen gums, bright red or purple color, gums that are tender or painful to the touch, bleeding gums, and you can have bad breath with it. The second type of periodontal disease is the irreversible kind, periodontitis. That's characterized differently by alveolar bone loss. One thing about periodontal disease too, periodontitis, it's an immune inflammatory host-mediated destruction of bone. So not only is it the bacteria inside your mouth, it's your body's response to that. So how do we recognize periodontal disease? What are the signs and symptoms, things that we need to do? We need to conduct a comprehensive assessment. There's three things that we're going to be looking at in order to come up with a full assessment for your patient. So it's like getting all the pieces of a jigsaw puzzle, putting it together so we have that full picture. The first thing we'll be conducting is a risk assessment. Second thing, we're going to be doing a radiographic assessment, looking at their films, seeing what's going on. And third, we'll complete a periodontal charting. Let's get into more depth on these topics here. For the risk assessment, we want to identify patients that are at increased risk. Here's a list of the risk factors from the Journal of American Dental Association. So we'll talk in depth about these. The first risk factor could be age. Now, it's not necessarily because you're older that you're going to develop periodontal disease, but it could be it's accumulation of things over time. You can have that cumulative effect of tissue destruction throughout a lifetime. And also, as you age, you have other risk factors that can be related to periodontal disease. You have certain diseases that can develop, certain medications that you're on that could affect the severity. Next is socioeconomic status. It's shown that people with lower income, on the lower end of things, there's multiple factors that go into why this would affect someone's periodontal health. The first one would be poor oral hygiene. They're not brushing as much. Maybe they can't get the toothbrush or the toothpaste that they need or the floss in order to effectively clean their mouths on a daily basis. The second would be lack of education. They don't know about periodontal disease. They don't know about, they need to brush their teeth in order to have a healthy mouth. And the third would be related to money or a problem with access to routine dental care. They can't get to the facility, they can't afford it, things of that nature. We want to find out the history of their tooth loss. If a patient has missing teeth, we want to find out, is it because of decay? Their tooth has rotted out and had to be extracted, or just completely was gone, or is it because they have periodontal disease, the tooth became loose and it fell out? The reason we want to know that is because there's two different families of bacteria. The bacteria that causes cavities and then the one that causes periodontal disease. So we kind of want to find out a background and see if they already have the disease where they are starting to lose teeth for that. Next, we want to find out if the patient's pregnant. You're not going to develop periodontal disease from being pregnant, but if you're a pregnant patient with periodontal disease, it's been linked to preterm low birth weight for expectant moms. So we want to identify that patient that's pregnant, has periodontal disease, make sure they're controlling it so that we don't have any effects to the baby. Next, let's talk about tobacco use. Of course, tobacco use is not good for any situation in the mouth or for general health overall. Smoking in particular can enhance attachment loss and impair wound healing. So it can increase the severity of their disease. And then the final risk factor is systemic medical conditions. As mentioned previously, periodontal disease is the immune response to bacteria. So when a person is already systemically compromised, periodontal disease has a greater chance of causing more damage. And these conditions can work from both ends. If the patient has diabetes, the diabetes will affect the periodontal disease if the diabetes is not controlled, and the periodontal disease can affect the diabetes. So it goes both ways. We want to make sure that we're controlling the periodontal disease and that we're getting these systemic problems taken care of so that they don't aggravate each other. So let's review what we've covered so far. So what are some of the risk factors for periodontal disease that we talked about?
We talked about a person's age could be a risk factor.
No?
Seemed like their overall oral hygiene, you kept on talking about these bacteria that eat it away, and like, how do you get these bacteria? Is it just lack of brushing, bad diet?
Everybody has bacteria in their mouth.
Okay.
But there are certain types and certain types of bacteria that can cause certain things, like I said. Mm-hmm. The ones that are most common to periodontal disease are P. gingivalis, AA, and
well, do these things normally occur in your mouth, or is it like certain things you eat that give you them?
It's not certain things that you eat, no.
Okay.
It's things that can occur, and then there's other ways that you can acquire the bacteria, but it's not from food.
Oh, all right.
What were some other things we talked about?
Lack of education.
Yeah.
So and that's their social socioeconomic
Is there
status.
are there currently programs in place that have dentists entering into elementary schools and educating kids, like even just simple handing out toothbrushes or doing
There definitely are. We actually, that's one of the requirements for dental hygiene, is that we have to go into schools during our community projects. We go into a kindergarten class, and then we go into a first through high school. You can pick a grade. And I know that's a one-time thing, but there are certain dentists that do have outreach programs. There are low-income programs. I know at my daughter's school they have a dentist on site, and they send information home with the parent, and they can do exams at the school and even fillings. So it just depends on where they are in the state, who's looking over the school, and who's taking an interest in that. But there is definitely a need for more people to do it.
That's what I was thinking when you were saying that. I was thinking it would probably be a good idea, like rather than just pressing just dentists on site, but someone actually going into the classrooms and teaching even parents who can't have their kids go to that dentist.
Exactly. And there are programs too, and this, this is more, that's more for kids. It's basically, it's geared more towards cavities. Because children don't have periodontal disease as much, periodontitis especially, as adults.
We see it more in adults or children. So
I mean, there is juvenile onset periodontitis, but that's really rare. But like I said, it's more cavities for kids, so it's more about the education of oral hygiene for them in that respect. And also they have sealant programs where they can go into low-income schools and get the kids' molars sealed to make sure.
Preventive care, and then education for the adults on continued.
Well, and that's the thing with periodontal disease too. If we can get these patients early enough and get it prevented or stopped in its tracks, then we won't have this aggressive thing where somebody doesn't come in the dentist for 10 years, they come in, and then it's to the point where we can't save their teeth at that point. Alright, so let's move on to the next question. So how do we get this information? How do we know, how do we find out their age? How do we find out their techniques at home? How do we find out if they're a smoker? What are some ways that we can do that?
For the patients?
Yes.
Don't you just simply ask them?
Yeah, exactly. We want to do a history with them. So what do you think would be the best approach for that? Do you think it would be best to give them something to, like some paper to fill out, or talk to them?
I think talking works the best, because paperwork, especially with men, they just don't like filling it out.
That's true. I mean, seriously, a lot of days, if a new patient comes in and needs to fill out paperwork, their wife is sitting there filling it out while they're doing nothing.
I think it would be good to ask them to show you how they brush, because a lot of times if you tell them how to brush, it might come off in a condescending manner to the patient through embarrassment for them. So sometimes they think, if I was a patient, I probably would be more willing to offer maybe more honesty to the dentist if they said, hey, can you show me an example of how you brush? Because then at that point it becomes educating while you're watching where their flaw might be. And then you can say, oh, I see that you're doing that. Can I give you advice or suggestion on how you can avoid other deteriorations in other areas or something?
Perfect. I think it's a combination too. Like you said, Rocky, that you would prefer to talk about it. Yes. You also have to consider in a dental environment that you're time constrained. So I think that the best way to do it is maybe a combination. We give them the pamphlet to start filling out. They answer those questions or pre-screen them, and then if we see something come on there, that's when we dig in deeper. So when we get that patient in their chair, ask more questions, find out what's going on. And then like Don said, it's more about coming at them at a level where they're not feeling like you're condescending them. Okay, so let's move on. So we've completed our risk assessment, and now we're going to do the radiographic assessment. So this is the first thing we do, is we need to know what's going on underneath that gum tissue. We need to know what's going on with the bone to just see if they're healthy. So the American Academy of Periodontology states that radiographic bone loss is characterized by measuring from the CEJ to the crest of the alveolar process. So the CEJ, we're looking where, that's the cemento-enamel junction. It's where the cementum and the enamel of the tooth meet. So we're going to measure from here. You can see the tooth. It has three areas. The outermost white portion, that's our enamel. Underneath is our dentin, and then we have our nerve here. So where our enamel ends, and then here's our bone, this white here. So we want to measure from here to here, and that's how we get our measurement. So 1 to 2 millimeters from here to here is actually considered normal. When we have 3 to 4, that's when we have mild bone loss. 5 to 6 is moderate, and 7 and above is severe bone loss. And then another thing we're looking for is presence of calculus on the radiographs. Now calculus actually is not a causative factor of periodontal disease, but it's a contributing factor, if that makes sense. So what happens with calculus is it's an irregular surface. When you have like nooks and crannies and different things, more bacteria can accumulate there. So we do have increased bacteria when we have calculus because it just has more places to hide. Alright, so not only are we just looking at the severity, we're looking at the type of bone loss that we have. We can have vertical bone loss, where you can see it comes at a slant. And then we have horizontal, which is more of a uniform bone loss. So we want to document that kind of stuff when we're looking at radiographs. Documentation is key when we're filling out, when we're submitting to insurance. They want to know what we're looking at. Also, we want to compare what these radiographs look like from now and then when we take bite wings every year to 2 years, just to see how everything's progressing. Some other things we're looking at on the radiographs, we're looking at the periodontal ligament space. So as we talked about earlier, that periodontal ligament is where we're having the fibers in between. When we start to see widening of that space, that's when we know that it's the beginning, we're getting some damage there. We need to document that. We're also looking at furcation involvement. What that means is where the roots split, we want to see if there's bone loss there. Can you see that dark space in between the the roots there? That's when we know that's involved. So we know when we're looking at this patient, when we're taking measurements, we want to check that spot too to see if we can get a probe in there, because bacteria is getting down there. And that patient is probably having a hard time getting anything in between that root surface to get it cleaned out. Alright, so quick review on radiographs. What are we assessing on the radiographs? You guys remember?
Bone loss.
Yeah, exactly.
In the last slide that you were showing, where there was that dark spot.
What that means, what the dark spot is the radiation is passing through, so there's no bone there stopping it. So that's how we know that there's no bone there. And then
So
it sees the denseness.
It'd be hard for them to know that they need to get there and clean. Can they see that hole?
It depends if the person has recession of the gum tissue or not. Because if the gum tissue is covering it, no. But if their gum tissue is recessed enough and you can visibly see it, then yes, they'll see that furcation.
Interesting.
So what are our levels of severity?
Are you talking about the numbers where you're reading out?
You don't just tell me like yeah.
The 7 was horrible, 5 to the 3 moderate.
1 to 2 is healthy.
Yeah.
So 1 to 2 healthy.
Okay.
3 to 4
is this
mild.
millimeters?
Yes, 3 to 4 millimeters is mild.
Okay.
5 to 6 is moderate, and then 7 and above is severe.
All right.
Good job. Alright, so we've interviewed our patient, we've gotten all the risk factors information, we've assessed their radiographs, now it's time to tell them to open wide and we're going to do our assessment inside their mouth. Alright, so as we examine their gingiva, there's 3 descriptors that we're looking for. We're looking for the color, contour, and consistency of the soft tissue. So the color can vary. It depends on the person. Just like a person's skin color can vary, so can the color of their gingiva. When we're looking at health, the most generic term they use for health is coral pink. But it can have pigmentation, like I'm saying. You can have brown spots on the gums. So if you see that in a patient's mouth, don't automatically freak out and think they have cancer. It's pigmentation. And then for disease, it can be anywhere from red to white to blue-purple, and you can see from the picture, there's a lot of variances. So we want to look for uniformity of color as well. So say this person, they look extremely healthy. If we had some localized areas of gingivitis, it would be a different color in the spot. Now for the contour, we're looking at the gingival margin. So that's where the gum tissue is against the tooth, and then we're looking at the interdental papilla, the gingiva that goes in between the teeth. In health, the gingival margin is going to be knife-edged, flat. It's going to have a scalloped appearance. The gums are going to go against the tooth, and they're going to fill the spaces in between the teeth as well. In disease, we can have rolled, puffy margins and bulbous papilla, or you could have a papilla where it's been flattened. Now, if somebody has spaces in between their teeth, they ask them, it can be flattened as well, so that's something to keep in mind. But if their teeth are right up against each other and we're seeing holes through those, and that papilla is flattened out, it's probably a sign of disease there. And then the third thing we're looking for is consistency. In health, it's going to be very firm to the touch. You're going to touch it, it's going to be nicely attached to the tooth, keeping that tooth nice and healthy, protected. And it's going to be resistant to movement when you're pushing on it. For disease, a term for that would be if you're touching and it's spongy, soft, edematous, that means it's filled with fluid. You touch it, it moves easily. That's when you know that's a sign of disease there as well. So what do we include? So we've looked at their gingiva, and now we need to do a perio chart. So here's what the American Dental Hygiene Association has set out for guidelines and what to include in a perio chart. So we'll go through these one by one. Probing depths. It's everyone's favorite thing. Your patient will ask you, oh, is this where you stabbed me a million times to go around my teeth? It's everyone's favorite part to go to see the hygienist. So there's 6 measurements per tooth. When we're going around the tooth, You have the side against, you have the buccal side, which is the side by your cheek, and then you have the lingual side, which is the side by your tongue. It's 3 on each side, 1 on the distal, 1 on the direct buccal, 1 on the mesial, and then same for the lingual, mesial, distal, and direct lingual. When we're going around, we want to make sure we have the proper technique of using the C-shaped grasp. We want to fulcrum to make sure we have accurate pressure. We're applying that. And then we want to make sure that we can read our probe. You can see here how many different probes are. This is a furcation probe, but you can see how all the markings are different on all these. Of course, we take our measurements in millimeters, and so this is going to be 1, 2, 3, and it has a band for 4, 5, and then this is a 3, 6, 9, 12. So you want to make sure that you're familiar with that before you start taking measurements.
You're actually measuring.
You're measuring the base.
You're not just poking us and hurting us. You actually have a measurement gauge.
Mm-hmm.
Interesting. I always just thought they were poking me.
So for probing depths, 1 to 3 millimeters is what we consider normal and healthy. And then when you're talking to your patient as well, you want to, when they're asking about it, 1 to 3 millimeters is what we can reach down with our toothbrush and our floss as well. So once we start getting those deeper numbers of 4 or higher, that's when we have trouble cleaning those areas, and that's when we have we could possibly have disease, or it could be something's triggering your inflammatory response in your body.
When you were saying before you want to let your patient know that, I think I like that you said that, or that you're explaining that to us, because until right now, I honestly didn't know why they'd be like 1, 2, 3, 3, 1, 1, 2, 1, like they're just be reading numbers. I'm like, what are they? What is 1, 2, 3? What are they talking about?
And that's one thing you want to, whenever you're doing anything in somebody's mouth, you want to tell them beforehand, this is when I'm doing it, this is why I'm doing it, so that they're not sitting there wondering, oh, is that bad? You want to give them the knowledge beforehand so they're prepared for what's going on.
Because I never knew that was linked to periodontal. Like, I've heard Daniel and I've heard other people and dentists and yourself explain that you're periodontal, but I never knew that the number system was linked to periodontal checking. I just knew that I always thought they were measuring my gums or how big they were or something. I didn't know that's what the link was.
Okay. So as we're going around, to get accurate probing, we want to make sure that we have our probe positioned correctly. And Dawn, like you were talking about, you didn't understand what the health was. So when we're doing a position of the probe, so we have what's called junctional epithelium. That's where our tissue is attaching to the tooth. In somebody that's healthy, when we're probing in there, the probe touches the junctional epithelium, and it's going to be above the CEJ we were talking about. It's above that cemento-enamel junction. Now, if somebody has disease, that probe's going to touch the junctional epithelium on the root surface. So what's happening is that epithelium is moving further and further down the root, and that's why we're getting that deeper measurement.
You're saying it's touching the root system.
Root surface.
Root surface. Would the patient experience any type of pain?
I mean, it just depends on the patient. They're not going to experience pain just because you're touching their root. Usually it's because they have inflamed tissue that they're feeling pain. So next we want to use the proper stroke technique. You don't want to just jab it in 6 times and get your 6 readings. You want to slowly walk your probe around, because the depth of the pocket can vary depending on where you are, and then you're going to record the deepest reading for that side of the tooth. And then for adaptation, we want to make sure that we're keeping that tip, which the tip is defined as the first 1 to 2 millimeters of the probe, is in contact with the tooth surface. Someone can experience pain if you're out into that gingiva and you're scraping up against the side of the soft tissue instead of keeping it nice and flush against the side of the tooth.
Okay.
And then we want to keep that probe parallel to the long axis of the tooth, because if we're looking at readings and we're going this way, you're going to get a different reading than if you're actually going parallel to the tooth.
Some people experience pain just because they have a sensitive mouth, because generally when I go, I get low numbers, 1s and 2s, and I think I've heard them say a 3 before, but for me personally, it hurts when they do it to every single one of my teeth.
And it could, I mean, have you noticed that with every clinician, or is it dependent on the person?
It's not one specific person. It's been since I was young and growing up. It's hurt me, so I didn't know if that, some people just experience, they're more sensitive in their mouth, so they don't think that that's necessarily that something's wrong, or that...
Well, I mean, just because you're feeling pain doesn't mean that you have periodontal disease. You're right, it does depend on you, it depends on how much pressure the person's putting on your mouth, it depends on how you're brushing and flossing, so I mean, it just depends on the person.
Okay.
But it really shouldn't hurt. It shouldn't. I mean, it can be uncomfortable, but it shouldn't. You shouldn't be having your patient flinch, and unless, like I said, they have severe disease and they are extremely sensitive. Then we can use a topical anesthetic to help numb that. All right. So next, we're going to talk about bleeding points. That's one of the signs and symptoms. It's an indicator of disease, but not necessarily all the time. So we'd have to take this in consideration with all the other factors that we're taking. And then one thing to keep in mind too, as you're taking the measurements, it might not necessarily start bleeding right away. So I would, once you're done probing, you want to recheck the gums and see if you missed any bleeding points. Next is the separation. Trust me, the first time you see pus coming out of somebody's curvicular fluid, you're going to know that's not right. It can be kind of disturbing at times, so just try not to freak your patient out and just record it on your sheet. So a mucogingival defect. So what happens is we have our gingiva and then we have our mucosa. So our gingiva is extremely keratinized tissue, and then we go to the mucosa, which is the softer tissue when you get lower. If we're getting, if it's transferring from the gingiva down there, that's a pretty large defect. We want to make sure we're monitoring that so we can document the severity. Next is recession, and this is kind of what we were talking about, like with health. There's two ways. There's positive recession and negative recession. What positive recession means, and it kind of sounds weird, positive is actually when we can see the root surface. Negative is when it's coming up, it's negatively covering the tooth, if that makes sense. So when somebody has negative recession, like I said, it shows the root. Positive, it's going to cover up more of the crown of the tooth. So with negative recession, you're going to have to feel the CEJ with your probe. And then when we have the root exposed, you can see the CEJ, but I mean you also want to feel it with your probe. But when the gum tissue is covering it, you have to feel with your probe to see where the gingiva is in comparison to the CEJ. So it's more of a feel for that. And some other things to consider with recession: just because a patient has recession doesn't necessarily mean they have periodontal disease. They could have a traumatic occlusion, meaning they're biting really hard and it's causing damage that way. Or it could be they're an aggressive brusher and they're abrading away that tissue on their gums. So we want to ask those questions, monitor it, and see what other signs there are. So like I said, it's fitting all these pieces together where we get the full picture of what's going on. So talking about attachment level, so that's where we tie in the probing depths, the pericharting, and radiographs. First, to get a true clinical attachment level, we have to combine the probing depth and recession. So let's go back to, remember that picture where it had the root? Mm-hmm. So say we're taking a probing depth, a measurement between the tooth and the gum, and we had 3 millimeter reading. And then we add to that the 3 millimeters of recession. So that's truly 6 millimeters when we add that together. So from the original spot where it started to where it is now, we have 6 millimeters of loss. Or 6 millimeters of that measurement. That's the full measurement. But then say we take a measurement at 6 millimeters and they have negative recession where they have the swelling. So say we take the reading and it's a 5, but then we feel the CEJ and we feel that there's 2 millimeters of negative recession, so that's actually a 3 millimeter thing, and it's actually, they might not have bone loss. And that's why we look at the x-rays, we look at the probing depths, combine it all together, and see if there's actual true bone loss. Alright, so let's review what we've covered so far. So what are the 3 major things we were talking about to include in a complete periodontal assessment? What was the first thing we talked about?
The depth.
Probing depth?
Yeah,
No, like to start the whole thing. So we talked about a person's history and their risk factors.
Okay.
And then what was the second thing we did?
Took a look at the x-rays.
The x-rays, the radiographs, and the third, that's when we do the
measurement and we check
the periodontal
recession.
charting.
Right.
Exactly. Perfect. Let me pull up this picture. It's a great representation of everything we've been talking about. There's no picture here of risk assessment. You know, the history we're asking them, but we know that. So we're going to talk to that patient, find out the risk factors, get their medical history, their social history, things of that nature. And then we're going to complete the periodontal charting, which is depicted in this first column here. It's taking the measurements. We're going to look at their gingiva, get a physical description with our eyes, and then we're going to look at the radiographs and see what's going on below all those structures. And then when we look at the rows here, we're looking at health here. That's where we have a healthy reading. Their gingiva looks really healthy, and there's no bone loss. We have gingivitis here, which is where we're getting maybe a little bit of a deeper area. The tissue might look a little swollen here, but then again we look at the x-rays, no bone loss. We have our mild periodontitis, deeper measurements, 4 to 5 millimeters. Tissue doesn't look the best, and then we look at the x-rays, and that's when we're starting to see some scooping out of the bone here, and we're dropping on our crestal bone heights here. For the moderate, and of course they're making the gingiva look worse as we go. We're getting the deeper measurements. We're seeing some horizontal defects here, and then we go to severe, and you can see, look, they put recession on this picture. The tissue's not looking that great, and then we look at the radiographs. We're having severe bone loss and even furcation involvement there.
Bone loss is when they're losing bone, or the gums are receding, so you're seeing more bone?
They're losing alveolar bone. And when you lose bone, you can have recession of the gums too. So I mean, it's all tied in together. So when we're losing the bone, and that's the thing, that's why we're looking at the gum tissue and we're looking at the x-rays. Because if you saw this person, would you think their bone looked like that? You wouldn't know. Because here, look how inflamed that tissue is. We don't know what it looks like underneath. So that's why it's important that we do all of these things to tie it all in together.
All of your radiographs are showing the lower portion, the jaw. Is periodontitis also for the upper part of your mouth too, or is it just affects the lower part of your mouth?
It affects everything.
Okay.
Those are just the pictures I found.
All right.
Any other questions? All right, thank you guys for coming, and I hope we'll be able to take this information and take it into the clinic with us and start educating our patients and identifying disease.
Thank you. Good job.